everyone. This is Sheila Bell, the Bell, and I'm so happy to be here for HERStory RVA, a virtual women's empowerment series curated with Black women in mind. And this week's programming is presented by Radio 1 Richmond and VCU Health. Again, I am Sheila Bell, excited to be here, your midday personality on Praise 104.7. You can catch me between 10 a.m. and 3 p.m. and often many times right here on Facebook and many of our other outlets. So let's talk about what we're about to talk about. Happy National Women's Health Week. Yes, and we want to help you take control of your health and to take the first step and join the celebration this week as we break down the 8 health conditions that disproportionately affect Black women and how to best prevent them. Now, Black women are often plagued with disproportionately high incidences or mortality rates for various health conditions like heart disease, breast cancer, and more. And it may sound scary, and it can be, but knowledge is power, especially when it comes to your physical and mental health. And in this episode of HERStory RVA, we are covering how breast cancer affects Black women at a disproportionately rate in comparison to other races. And joining me and helping me to facilitate this discussion is the team from VCU Massey Cancer Health. And first up is Dr. Vanessa B. Sheppard, professor and the Teresa A. Thompson Memorial Chair in Cancer Prevention and Control, the Associate Center Director and Community Outreach Engagement and Health Disparities at the VCU Massey Cancer Center. Welcome, and how are you today?
Thank you. I am doing well today. I'm just so excited to be here and to talk about this topic with you. It's so important, so glad to be here.
I'm glad that you're here too. Just a little bit about her for those who are listening right now. In her role as Associate Director, Dr. Sheppard serves on the Cancer Center's Executive Committee and leads Massey's community outreach and engagement efforts through the Massey Office of Health Equity and Disparities Research to advance evidence-based education in high-priority disparities and minority health research across its various research programs and themes. This critical area of research also explores why certain groups may be more likely than other groups of people to develop cancer, experience cancer-related health problems, or die from cancer. She developed and facilitates a disparities work group and collaborates with other cancer centers leaders to foster transdisciplinary science focused on biological, clinical, and social detriments of cancer disparities. Also coming to the virtual stage next is breast cancer research, Maria Thompson. Welcome.
Hello, thank you for having me.
I'm so glad that you're here. And for those who are also listening, Dr. Maria Thompson is an associate professor in the Department of Health, Behavior, and Policy at VCU and is an affiliate faculty member in the Office of Community Outreach and Engagement at the Massey Cancer Center. Her work focuses on promoting informed and shared decisions making through effective communication and measuring and evaluating social, cultural, and health disparities that influence cancer survivors and family caregivers, information needs, knowledge, attitudes, and behavior. Our next guest is medical oncologist Mary Helen Hackney. Welcome.
Thank you for having me.
We are so glad that you are here. Dr. Hackney is a medical oncologist and the medical director of community oncology at VCU Massey Cancer Center and VCU School of Medicine. She is also an associate professor and the director of quality improvement in the Division of Hematology and also oncology, also in the palliative care in the Department of Internal Medicine at the VCU School of Medicine, a physician board certified in medical oncology and palliative care, and a member of the Developmental Therapeutics Research Program at Massey. Hackney is also specialized in the treatment, also survivorship, and risk reduction of breast cancer. She also serves as co-chair of VCU Health Cancer Committee and has significant responsibilities for maintaining Massey's accreditation with the Commission on Cancer and National Accreditation Program for Breast Cancer. And again, welcome.
Thank you. Thank you for this opportunity.
Again, we're so glad that you're here. And also, last but not least, is breast cancer survivor and advocate Wanda Lucas.
Hello.
And hello, and again, thank you for joining us. And for
Thank you
those
for having
listening,
me.
yes, Wanda Lucas serves as Vice President on the Board of Directors for the National Breast Cancer Coalition. She is a graduate of the Project Lead Institute and has served as a consumer reviewer for the Department of Defense Breast Cancer Research Program. She is a founding member of the Georgetown University Breast Cancer Advocates, was recognized as a champion of change by the White House in 2011, and honored for her grassroots advocacy by NBCC in 2014, and she was diagnosed with breast cancer in 2006. Again, thank you, panelists, for joining us today. Yes, and today we're learning how Massey is addressing breast cancer disparities and about efforts Dr. Sheppard is leading to build connections between the community, care, and research. So we have a heavy topic that many people need to hear, but also from heavy hitters joining us. So again, thank you so much. And Dr. Sheppard, I'm going to start with you because you wear several hats at VCU and recently shared some of your perspectives about cancer disparities and community engagement when First Lady Jill Biden visited Massey back in February. Please tell us a little bit more about that visit and how this connects with your role in addressing breast cancer disparities experienced by Black women in this area.
Absolutely. I was so inspired by that visit, both professionally and personally. You see, I actually had met Dr. Biden at the vice president's residence years ago, 2014, and I was with Miss Wanda Lucas, who was we were celebrating her being a champion of change. At that time, we were taking pictures, and I was smiling on the outside, but internally really wrestling with some news I was waiting to hear from my physician. So then let's fast forward to 2021, and I have an opportunity to now meet the First Lady and not just take a picture with her, but to be on stage with her as a thriver, to be on stage with her leading an important initiative here at the Massey Cancer Center. And so it was so exciting for me just to think about what transpired in that time and to now be at a place where, yes, I'm still doing research and I focus on breast cancer research, but to have the opportunity to be over community engagement. And so Dr. Biden's commitment to not just describing disparities, but eliminating them was exciting for me. And Massey, we are unapologetically focused on disparities as a cancer center. We know that we have to take up the mantle to do this. And so for me to be able to talk to her about our efforts to reach all populations, but specifically African American women, to address disparities was inspiring and the shot of the arm that I needed as we reach our goal to infuse community outreach and education, as you said, to give knowledge and power to all women.
That's awesome. And when we hear a lot about breast cancer disparities in the media and that Black women are more likely to die than other racial ethnic groups, what are disparities and why do we have them? Dr. Thomas.
So disparities are variations in rates of disease, like cancer incidence or death. And we get them when there's unequal access or availability to resources and opportunities that then lead to these variations in outcomes. So in terms of breast cancer mortality, for example, some of the things that contribute to disparities could be advanced stage of diagnosis, barriers to accessing high quality cancer care, barriers to accessing insurance coverage.
Oh, wow. Black women are also more likely to die of breast cancer than women of other areas. Why is that? And what steps can Black women take to reduce their breast cancer risks? Dr. Sheppard?
Sure.
Dr. Henley?
Sure. So, it's there are things that are within our control, obviously, and things that are outside of our control. And so the reasons, some of the reasons Dr. Thompson mentioned in terms of the disparities, and it's complex when we think about biology, when we think about social determinants of health in terms of where people live and access to care. What we do see in African American women that are impacted at a younger age. We are concerned that rates of mortality in Black women are still about between 39 and 40% higher than their white counterparts. And so we think about this across a continuum of what could we do for reducing risk, what can we do in terms of detecting cancer earlier and treatment. And we do see more aggressive tumor biology in African American women. And again, that's complex and many contributors to that. And some people may have heard of, for example, triple negative breast cancer. And Dr. Hackney, I know, is going to join in as well. But that's sort of the big picture in terms of when we think about some of the reasons. And then there are things that Black women can do that we believe to reduce, I would say, the risk of recurrence and potentially risk of adverse mortality. But Dr. Hackney?
Yeah, and you really made a clear factor. We tend to see breast cancer in African American women often as younger women. We think of the median age for breast cancer and globally at around 62, but we see it in the late 50s, early 60s for African American women. But they also have the highest group of breast cancer in women in their 40s. And more often are the aggressive types of breast cancer, which have a higher risk of mortality, but also can be very successfully treated when given the right treatment. And so that really becomes a key factor in terms of reducing mortality. Part of the advocacy we need to do is to get people in earlier and make sure people are getting the appropriate screening, and then think about behaviors and lifestyle things that might help reduce that risk of getting breast cancer.
Dr. Sheppard and also Dr. Hackney, before we go to Dr. Thompson, I want to jump in also because there was something that you said that there are some things that women can do to help reduce their risk. What are they?
Well, from a lifestyle issue, you look at controlling obesity. We know that obesity increases the risk. Controlling your blood sugar, that people who are pre-diabetic or diabetic have out of control blood sugar may have increased risk, contributes to the growth of the cancer. Not that sugar feeds the cancer, but that blood sugar out of control can increase inflammation and other factors that might increase cancer. So obesity, blood sugar control, exercise, getting the body healthy, all of those things are some lifestyle issues. Limiting or reducing alcohol consumption, again, a lifestyle issue. We can't change some things. We can't change our age. We can't change that we're female. Those are our biggest risk factors. It's important to know your family history and know who in your family has had breast cancer or prostate cancer or pancreatic cancer, and use that family history to determine when you need to be screened so that you can start your screening at an appropriate time. I always encourage people to get mammograms starting at age 40. But if you've got a family history, you may need to start your screening at age 30 or 35 and be aware that that won't prevent you from getting breast cancer. But if you catch it early, you're going to be able to get better treatment, less likely to have bad consequences. So smaller is better, catching it early. So you work on lifestyle issues, you work on getting your screening done early, and you know what your risks are from family history as well.
We've also heard that sugar also feeds cancer. Can you guys speak to that? We've heard that from many people, not only like you're talking about lifestyles, but people like stay away from the sugar.
Really, the issue is don't get fat, or if you're fat, try to get appropriate. Sugar, it's all our body feeds, our whole body feeds on sugar, whether it's cancer cells or good cells. But sugar, empty calorie sugar, tends to increase our body mass, tends to make us heavier. And that is a risk factor for breast cancer. Not just breast cancer, but endometrial cancer, pancreatic cancer, some other cancers as well. So we need to be body weight appropriate, not too fat, not too thin. And so if we eat less sugar, we can help keep that body fat under control. But if you have a piece of birthday cake to celebrate your birthday, you're not feeding your cancer. So the key is that global moderation and control.
Yeah, I think
that's
yeah, I think that's an excellent point because it's very complicated when we think about sort of our diet and risk, and so they're very different types of scientists to kind of focus on what's happening at the cellular level. The other lifestyle factor I just want to also mention is smoking.
Yeah.
And so don't smoke and quit if you are. And with regard to family history, and there are a small proportion of women that may be at risk for hereditary breast or ovarian cancer. And so that's where conversations and knowing your family risk to know if and when, you need to seek genetic counseling in order to avert hereditary breast cancer. So those are some of the things that women can be aware of to do in terms of moderating what they can control.
That's so good. What is also the ideal age for Black women to get a mammogram? I think you just spoke on that. And how is VCU also helping to improve access to mammograms for women who may face barriers to screening?
Well,
Dr. Sheppard, Dr. Thompson?
Well, so I think as Dr. Hackney had said earlier, or maybe Dr. Sheppard, recommendation is to start screening at age 40 for average risk women. But if you have a family history or you have had breast cancer in the past, then, talk with a doctor, speak with your doctor to decide what at what age is best for you, most appropriate. In terms of what VCU is doing to help improve access to mammography, I just wanted to say that beginning in June, we're launching a program called Mammogram Mondays. And that's the plan is to have once a month, we have a dedicated day, the last Monday of the month that we're going to call Mammogram Mondays. And we have a community health navigator who's going to help women who are aged 40 and up, so at average risk for breast cancer, to get scheduled and complete that screening mammogram.
Okay. And are there important things that are also being learned about enhancing access to screening and risk assessment in Black women? Dr. Thompson?
Yeah, so, with support from Greensville Memorial Foundation, we've been working with several community partners to navigate women living in rural areas of Virginia to mammography screening. And so we've learned quite a bit from that so far. So we've found that, for several women that we've talked to, it's been many years since their last mammogram, or, quite a few women have never had a screening mammogram. But importantly, we've spoken with women who have themselves had breast cancer in the past or have a very strong family history of breast cancer and other cancers that, have gone many, many years since their last screen. And so it's really, really important for those women to get in and get those screens regularly. So, our navigator, thinking about what kinds of things the navigator is helping to overcome some of the barriers they're addressing, things like providing education and answering questions so that women feel comfortable sort of walking through the process. What's going to happen before, during, and after? I've got some questions about this aspect of the process. The navigator can help walk through that, or, figure out who's a good person to answer that question. The navigators also help with scheduling and with some transportation issues to really make sure that there's no barriers between, getting that woman into that mammogram screen.
I think it's also important for us to have conversations like this. And I remember when I had my first mammogram, and when I was looking at the screen, I saw these two white dots. And I was asking the nurse, what was that? Because something to me, a bell went off. But she says, well, I'm not in a position because we really don't interpret. I'm like, good and well what was going on. But she didn't want to tell me what was going on. But that reality check, after you have that mammogram, you see, then you have to go back and have more images done. It's like when that initially happens, at least for me, that I think after the maybe 8th or 10th image, something in me just started to shake me to my core. Like, this is getting really serious. But then when you go through this, and just like I went through, many other people go through, when you are able to catch this thing early, that's the blessing. And some people are not aware that you can catch this early, even it may be a big thing that you have to deal with. When you can catch it early, you can actually resolve the issue and resolve the problem. And sometimes I think people just don't want to deal with that initial situation because it touches you from the top of your head to the core of your feet, inside and out, and you have to deal with it. So maybe that's something else that we can do, just to put more stories out there, more testimonies out there, more testimonials out there, so people could hear their story where they were. My next question is, we often hear that Black women also don't get the treatment they should. Can you share some of your experiences in this area, Dr. Sheppard, Dr. Hackney?
Sure. So, I think when we think about the cancer care delivery system, some of the things that Dr. Thompson just mentioned is to try to help bridge and reduce the gaps that people may experience and really walking people through. One of the things that's important is for women to be empowered to be their own advocate. And so sometimes we often say, well, Black women delay getting care. They don't seek care as frequently. There's a delay to diagnosis. And what we found in our work is that some of the delays experienced, it wasn't just because a woman said, I don't want to go. Sometimes it was because that first connection she had with the healthcare system, she was dismissed, where her provider said, you're either too young, because that's been common, you're too young, can't be breast cancer, or they may feel something. And so we want people and to, even if you have a mammogram and you still feel like something's wrong, you get to be able to follow up so that you go to a provider or a place that will listen to you, because we often know our own bodies. And so across this continuum of care, we do see disparities in treatment. And what's very important is patient-centered care. What we found is that when African-American women have strong relationships with their physicians, with their healthcare systems, they're more likely to not have delays. We've seen statistically significantly different and reductions in delays to care, in receipt of chemotherapy, in receipt of adjuvant endocrine therapy. Some of the treatments that we know are critical. And so what's so important for me is that the good news is that when you have a great physician, and the medical oncologist specifically is that person that's coordinating all the aspects of the care that you may need, we find that Black women do better. And so to me, like you said earlier, Ms. Bell, you can't change, and Dr. Hackney said this, you can't change your age. Some of us are working on it. You can't change, being a woman and having hormones, but we can have great care, so we can do something about that. And I am very proud and honored with Dr. Hackney. She is that physician that gives patient-centered care. I hear it in the community, and know it firsthand, and that can make the difference.
I've heard it in the community too from a couple of her patients who speak very highly of her. And often you hear about Dr. Mary Henley. I've heard that so much. So it's just good to have you part of this conversation also. Also, we hear a lot in the media these days about clinical trials, and Black women are often underrepresented in these clinical trials, often due to poor access or other factors. Why are clinical trials important, and what can Massey and the medical profession do to increase participation among Black women? Dr. Sheppard, Dr. Hackney, Dr. Lucas?
I'll let Dr. Hackney start with that.
The way the reason that we have more women surviving breast cancer these days is built on the research that has been done for decades. And a lot of that research has been in the context of trials. When you treat cancer, it's not like making a pot of soup where you can just pull a little bit of this, a little bit of that. There has to be a little bit more regulation and standardization about how we're going to treat so that we can get the best response and the best outcome for a patient. And so clinical trials are built on old clinical trials, and that's how we gain knowledge to better treat the next generations of people with cancer. And the hope of a trial is it may also give that individual participating a benefit by being on the trial. I like to use the example of the NSABP, one of the largest groups that does clinical trials. When I started practice, they were working on breast cancer trial number 23. We're now working on breast cancer trial number 61, which means they've brought all these different trials on board. And trials are at any stage of breast cancer. People think that they're only when there's nothing left to do. But we have trials for symptom prevention. We have trials to monitor the heart. We have early stage cancer trials with chemotherapy. We have an early stage trial looking at a better radiation therapy, different trials for surgery. So trials can be at any point. And when you're treating cancer, you're treating cancer. You're not using placebo trials. So you're going to get real treatment. And I think that's one thing to not be afraid of. The way we approach trials now are that there is a very in-depth consent form. The trials are reviewed by several different safety boards to make sure they are scientifically and ethically appropriate to be done. So the fears that were in the past, we have tried to calm down now because of the importance of these trials for making a difference in future cancer care. Your doctor should talk to you about these when somebody comes in, and it could, as I said, it could be at any stage. But that's how we gain knowledge to not only help that individual, but might also help that next generation and help us build forward so that we have less death from breast cancer or any other cancer.
Dr. Hackney, thank you so much. Also, Ms. Lucas, did you want to chime in on that?
I would love to, as someone who participated in a clinical trial. So I second everything Dr. Hackney said about the importance of clinical trials. I think it's extremely important for Black women to be involved because we want to know how these treatments and these protocols affect a variety or a diverse set of patients. Women with different breast cancer subtypes, different ages, geographic locations. So we need to be represented in these trials. I'm also aware that we are underrepresented, and I think that's due to a lot of reasons. Sadly, medical mistrust is still very prevalent in the African-American communities. And I think there's some things that we can do better. I think that sometimes clinical trial protocols can appear to be too rigid. Mm-hmm. And I think the patient needs to speak those things and say, can we make some changes? I had to do that. Yeah. I think that medical professionals can also appeal to Black women about the importance, but also appeal to their innate sense of being of service. I didn't do a trial to benefit me. I said, I think they'll learn something from my participation. Wow. And they did. I was in a soft trial, so they learned a lot from that trial. Yes.
Very, very big trial.
I also think, Dr. Sheppard, you brought up like those strong relationships with the healthcare team. I think the timing of when the ask is done is important. I think it's also important who does the ask or who introduces a patient to the research associate. Is it that I had a great breast surgeon that I love, and his patients, we still fight over him to this day. Anything he asks us to do, we would do. So I think that trusted professional does make a difference. Yeah. I also think that we meaning patient advocates, survivor advocates, can work with medical professionals to ensure that the information about the trials is in lay language. Because a lot of times it's in all this medical jargon. So I think there's some things that we can do together to increase the representation of Black women in clinical trials.
Let me ask you this, Dr. Lucas, and also everyone else. When a woman first hears that you have cancer, I don't know if it's necessarily about thinking that you're going to be transitioned out of this world, but there is a place in your mind that you're thinking, how am I going to deal with this? You've got to figure out, how am I going to deal with this? And then I'm thinking from the doctor's standpoint, you may want to think about, do you even have support? Because some people are by themselves, they are single, and you get this diagnosis and you've got to figure out, how am I going to deal with this? How am I going to just digest everything that's coming at me? And then you can have different situations that comes up. For me, like I had a port that was put in, but then the port got infected the first go round. Okay. Right after I got my first treatment. Then that happens. Then you got, who do you call if something happens? Then you get a PICC line. And the PICC line that was put into me, it wasn't done by you guys. Whatever they were trying to put on my arm to numb the area, it did not numb the area. No. So I went through pain that was so excruciating. My body went numb. I couldn't even understand that. Yeah. But if you're by yourself, what do we do to help women who are by themselves to deal with this? Because you get the diagnosis and you walk out the hospital, then what? Anybody.
Well, Dr. Thompson mentioned patient navigators. They really serve a great a role in patients' care these days. I think back in the day, we didn't have patient navigators, but we do now, that really help a patient understand what they're facing, how to access services and appointments. And then there's this great program called Sisters Informing Sisters, that Dr. Sheppard created, where we teach advocates, we teach women how to be their own best advocate. I know I was not the usual patient. I asked questions. I challenged. I knew that I could make my own decisions. I wanted to understand my options. I recorded conversations. I did my research. So I will also say that I understand when women, freak out when they get that diagnosis, because we meaning total community, we don't always promote that people are living and thriving after a diagnosis. So when people hear you have breast cancer, all they hear about is people that have died, and I've worked with women like that. I have a friend that just finished treatment and I had to talk her off a ledge, So that's a very real feeling that women have when they receive that diagnosis. So there are programs in place to help women, calm down and understand what they're facing and understand what treatments are available and give them access to service, to treatment.
I think another thing is that, you made a key comment, more and more women are single women, either the breadwinners, they're leading the family, they're taking care of children, grandchildren, they're taking care of elderly parents, and they tend to neglect themselves because they're the caregiver for everyone else. And I think one of those key points is when that diagnosis is made, is making sure that somebody touches them, be it the navigator, be it the social worker, of, what is your circle of care, and, how can we help you? Are there transportation resources? Is there a need for childcare, emotional support? Some of the women we see coming in with late stage disease is because they don't want to stop because they're caring for so many others. And we really have to embody them as a caregiver. If you take care of yourself, you're going to be able to take care of others. So let's ask for resources and let's see what is available for you, from cleaning your house to a card for a cab, whatever.
And
That's a good point. That's a really good point. I remember when I was going through, I wasn't even sure what to do, how to handle it. And you Google, you ask questions, and then it becomes this, you find yourself, for me, I found myself in a bubble. I just did not want to deal. I just wanted to figure out how I'm going to mentally, emotionally push my way through this thing. And I got through all the hard part, but then you go to church and people notice that you look a little different. But no one, thank the Lord, asked me any questions. They just kept me in prayer thinking something was going on. And after I lost 85 pounds, it's like, okay, let's start to share this story. But I was diagnosed in July of 2017, and I did not make it public until December 2017. And at that point, just everybody was, whatever we can do to help you out, because being in the position that I was in, I figured once it was out, it was out. So I wrote it into a story, and I had a few friends from the recording community who came on board, but it became a way that I was able to help other people and telling my story. And you tell the story in a way to let people know this is what happened, but this is where I am. And this is where I'm going. And this is how I've gotten through this. And this is what I'm going to be doing next. And it just worked out. And I just thank God for the people that came on board. But it's so good to hear, like Dr. Lucas is talking about, if you're passionate about just making sure that you push through, you're going to become passionate about helping others to get through it as well and becoming an advocate. I'm just loving that. Also, if you get breast cancer, what treatment options are available at VCU? I've got a story to tell on that, but I'm going to let you guys jump in. As you guys can tell, I'm feeling this. But Dr. Hackney, can you let us know about that?
Well, one of the programs, we've been taking care of men and women with breast cancer for many, many years. And we've had a breast cancer specialty clinic, but we cranked it up a notch about 4 years ago with the addition of Dr. Candace McGuire, one of the surgeons who works with me. And so if a woman has a new diagnosis of male or female, has a new diagnosis of breast cancer, they will participate in something called our BC4 clinic. And it's called the Breast Cancer Collaborative Care Clinic. And we have it both at our downtown Dalton office as well as at our Stony Point office. And the patient will come in and they will have the opportunity to sit down and meet with a surgeon, a medical oncologist, a radiation oncologist, a clinical research navigator, a regular nurse
Wow.
navigator, and a social worker. And so when they walk out of that visit, which is actually about 3 hours long or so, they will have talked to their whole team. And that team will have put together, this is the best plan we think for your cancer care. And it'll actually be written out on a sheet for them so they can go home with that information to be able to say, okay, this is where I need to go forward. And we have them leave with a lot of their future appointments already in place. But it's really important with a cancer diagnosis that you have that team around you. And it's your physicians, it's your nurses, it's your educators. And so, and we incorporate the social worker right up front too, so that we can sort of try to help identify what might be some of those needs that might be barriers to care down the road. So that breast cancer collaborative care, or the BC4 clinic as we call it, has really been a boon to getting that team approach that we hope will give better outcomes and get people on that road to healing and recovery.
It sounds like a wonderful program. I know that many other people could probably be blessed by that, to walk in and be able to talk to the entire team like that, versus coming in, getting a diagnosis and being sent on your way. Wow. And that plays a lot, again, into the advocate, because I want to go back to Ms. Lucas. It would seem important to have Black women to serve as advocates when you are dealing with a situation like that. Am I on point with that, Ms. Lucas, or what?
You are on point. It is so vitally important for Black women to become advocates. And I give all credit to Dr. Sheppard, who saw something in me that I didn't see in myself. And she basically said, you will be an advocate. You have what it takes. And I will say this, everyone's, sees the pink ribbons, and they've been marketed, a great deal. And yes, they've created awareness. So now that everybody's aware, we need more action. As an advocate, I would say that we need Black women to learn the science of breast cancer and serve as reviewers of the research funding applications, say through the Department of Defense or Susan G. Komen. I think advocates can learn about public policy and influence legislation, which will ensure quality access to care and continued research funding. I think advocates can challenge existing funding structures to include the patient or the advocate's voice. And I think advocates should support innovative research. We need some out-of-the-box thinking, around breast cancer research. I also think advocates can mentor new survivors so they can advocate for themselves. And as an advocate, you can teach others how to ask those questions and understand their options and make their own informed decisions. And finally, I will say what's really important is that we show that it's not solely a white woman's disease, that there are Black women who are living and thriving after a breast cancer diagnosis.
Wow, that is so good. And prayerfully, those who are listening understand, who have gone through, that they could be an advocate as well. Dr. Hackney, and I'm going to come at you all with this, and I pray that you don't raise your eyebrows too high, but because you may. Because when we think about the treatment of breast cancer, when we think about the treatment of cancer, we have been in this fight for many, many, many years. Why is it that we have yet to find a cure? Because I am sure in the seats that you all have sat in, that you all have heard the conversations. This has become a money game. It is about money, keeping people in a position where they just need the help. And when we look at the treatment and the medicine that is involved, I remember the bags that were coming at me, $30,000 a bag, $25,000 a bag, $40,000 a bag. Can somebody help us with these answers? Because I know these are conversations that people like myself have gone through, and we have sat back and wondered, like, what is going on?
Wow. So I
told you I'd make you raise your eyebrow.
Yeah, the money issue is huge. I think I'll start with the first question: is why haven't we cured and fixed cancer? We see more and more cancer as we're aging. It is a disrepair of our bodies, and as we don't die early of pneumonia or childbirth or complications, we live to older age. We see more cancer happening just globally, all types of cancer. And unfortunately, there's not one switch that turns off all cancers. There's a type of leukemia has one abnormality. They've got that switch turned it off. With breast cancer, there are multiple switches that make breast cancer happen, that make cancer cells grow. And they've not been able to find one drug that turns off all the switches to turn off a breast cancer cell. And so that's one of the challenges of finding out the right drugs and how to help all the different types of breast cancer. So yes, there is a lot of cost involved. I wish drugs didn't cost so much. That just boggles my brain when I think about the cost. But it's not an easy fix, and we need to continue to encourage good research. I don't know how to make people make things cost less. It worries me, because it worries me that we're going to put too high a price, and that when we have a high price on some things, some people may be excluded from some treatments. So that always makes me concerned. But I don't know how we control some of that. Anybody have any other ideas?
Well, I mean, I think that, there's what you, Dr. Hackney, may do on a regular daily basis in terms of treating patients. And then there's the discovery portion. And then there are, drug companies that may disseminate, and, right. And so there's a lot of different players in this. What we do know is that, certain oral drugs or medications, for example, that may be generic. You think about women taking different types of adjuvant endocrine therapy, they can be less, the out-of-pocket cost is less, over time. What I feel confident about is, working with, professionals that are committed, that have the heart for this, that aren't in it, for themselves, for the money, that are really thinking through what is the best regimen for my patient. In terms of, when someone has a recurrence, that they're really thinking about the individual. And so I think that patient-centered approach is important. I think Wanda may have mentioned medical mistrust earlier, and, it's okay to be skeptical. I think it's appropriate to ask questions. What we never want is for someone to have a bad experience at a place or read something that may not be accurate on the internet and then sit at home. What we are seeing is that Black women are living longer. They are surviving, they're thriving. And we know that we can contribute that to more precise treatment. And so, right now, it's something that either goes in our arm or goes in our mouth. I mean, it's something that we've got to take, but, we take other things as well. And so I think that when the whole issue of sickness, whether it's diabetes, whether it's hypertension, we could say that there's an industry out there. And so what can we do to make sure that we are taking care of our health to the extent that where we have control? And so that's what I think is important. And I think that there have been successes in sort of cures, if you will, across the cancer continuum. We can point to some things that, colorectal cancer, we remove a polyp, we can get it before it becomes cancer. So there have been successes, and we probably don't talk about them enough. I think we probably talk about the hard things, but there have been successes and things that we can point to.
That is so good to hear. And the more that we hear, like the treatments that you all are offering, and listening to the team that people get a chance to talk to. I did not have that. And I know many of the people did not as well, but to have that many people to talk to have your questions answered, that is such a blessing, which is resulting in more women surviving. So what final advice would you give and have for Black women to deal with when it comes to relating to breast cancer? What would be your just final advice to them? I'm coming to all of you off of that.
I say you're your own best advocate. Be informed, because through information, like you said at the very beginning, through information you have power. If you don't feel you're getting the right answers, go get a second opinion. You're not hurting anybody's feelings, but if you don't go and get the information you need to make your best choice, I would say shame on you. You are your best advocate. Be there for it. So get the information.
That's so good. Dr. Maria Thomas?
I would say think about the regular mammogram screen. that screening mammogram, and talk to your doctor about when is the right time, the appropriate time for you to start that regular screen.
That's so good. That's important too. Miss Wanda?
Okay, so I would say I agree with everything that's been said, but the other thing that I recommend to women who are diagnosed is to call their insurance company. Find out what they will cover and what they won't. And that's what I found. For some reason, I did that. I don't know where it came from. I called and they were so supportive and encouraged me to get a second opinion. So there's something very empowering when you know you come into an appointment with a physician and you're armed with this system that's behind you. So I knew I was going to be okay. So asking questions, knowing that your insurance company will pay for everything you need. There's something so powerful about that. But I suggest that people or women are curious. Ask those questions and remember that you are in charge of your own life and you should make informed decisions. So that
is so good, because that's definitely something that I did not do. But because of the insurance company that I had, it took care of so much.
Right.
And after I switched the first place where I was being treated, and then came to a better location, amen, everything just worked out really well. Yes, ma'am.
I was going to say, I want to add one more thing. When I did that, halfway through my treatment, they called me, my insurance company.
Okay.
And my first thought was, they're going to drop me. I'm costing too much money. They wanted to make sure I was okay. They reminded me that mental health services were available to me. I couldn't believe it. I was on the call with the nurse for 30 minutes, and they were concerned about me. So I felt very special throughout my treatment.
Can we ask you the name of your insurance company? Oh, my goodness.
At the time, it was United Healthcare. They were fabulous. They were fabulous.
That's stuff that we need to know.
Yeah.
Dr. Vanessa Sheppard, final advice.
Sure. So Ms. Lucas is special. So I'll just say that. So I guess two probably big picture thoughts. So one is try to have people in your walk, whether it's the prevention in, taking care of yourself, that are informed. Sometimes, we have people around us and they're not as informed. And so we want them to be informed. So you're getting good advice. And these are people in your social circle. There's often a thin line, what I say, between faith and fear. And sometimes our fear, we mask it as faith, whether we want to follow up and do those things that we should do. And so we have to put ourselves first. And as Black women specifically, we wear a lot of hats. We're doing a lot of things for many people. And even people who work as breast cancer researchers can get behind on their mammograms. Even somebody that works at a cancer center. I won't put that person out here today, but, and so I say that we can all be in that situation. And so we've got to put our health first. It's not a luxury, it's a must. And so those things that we mentioned earlier that we know can help reduce our risk and our stress. So put ourselves first. And I think other things will help fall into place.
That's just good information. And I'm going to do my best to make sure that we share this conversation, because I still know women who are now over 50 years of age who have yet to have a mammogram. Yeah.
We'll have a number they can call.
Yeah. So, absolutely. 2 minutes of discomfort to save your life. 2 minutes each side to save your life of discomfort. It's easy. It's easy.
And that's exactly what I told them. I said, had I not had that mammogram, where would I be? And it was a situation where someone said, come on, because it was a health fair that was going on that weekend. And I knew when I went to get that mammogram, because I was feeling something in my left breast. I said, they're going to find something and I'm going to have to deal with it. That's when you just say, well, let's just deal with it and get it done. So I know had I waited, it would not have been a good thing, but I'm just so glad that I did have it. And now I'm someone regularly, every October, I have my mammogram done. That's just the way it is.
And Ms. Bell, one quick question. So yes. do you feel as good as you look?
Oh, wow. Wow. Actually, I'm doing pretty good. I am
All right.
pushing through, and I've learned a lot along the way. I've learned also a lot of conversation from this conversation as well today. But so many things like Miss Lucas, M.B.A, CPCC, was sharing with us. Yes, that you have to be an advocate for yourself. You have to pay attention to what's going on. You can't believe everything on Google. It will maybe push you in the right direction to maybe go somewhere to ask more questions for better clarity. But I really pushed, and I had a tough time. I really did have a tough time, but I thank God that I got out of the bubble. But what was so interesting when I was going through, I was in this bubble and became so peaceful. I just I like staying in the bubble. But then I realized when I started to get better, I've got to go back out and deal with the rest of the world. And that was a big reality check for me. But here's one last thing. I noticed when someone is going through, those who are close to you, your friends, you don't hear from them. And when I got better, I went to church and there were two people I was pretty close to. And I really wanted to know. I said, look, there's no judgment. I'm not mad, but why is it that I didn't hear from you? And everybody said basically the same thing. I didn't know what to say. I didn't know what to do. And it's important, I think, for people who are not even going through, but to understand when other people are going through, just to text, just to call, just to card, just to drive by and wave, because that support will get you through so much better. It's amazing. Did you feel like that, Ms. Wanda?
I do. But I think sometimes, like I know I didn't tell a lot of people when I was diagnosed. I told the people who shared my faith, who I knew were going to pray for me and not bug me, because that's just the kind of person I am. But sometimes when we're going through something, we have to tell people what we need. And I think Black women don't typically do that. We try to save the world, take care of everybody, and we're not used to being needy. And it's okay to be needy, but we have to be very specific or give people examples of what they can do for you. Cook a meal for me, walk my dog, whatever it is, so give people examples of how they can help, because a lot of times people do not know how to support you going through it. So
that is so good. I will say one of my friends came down and walked my dog, Mojo at the time. He was 110 pounds. And when I looked out the window, my friend was walking slowly this way. Then I saw her coming back, running this way because my dog wanted to come back home. It was such a moment. Ladies, this has been such a rich conversation, and I want to thank you all so much for being a part of this. Dr. Vanessa Sheppard, Associate Director of Community Outreach Engagement and Health Disparities at VCU Massey Cancer Center. Also Dr. Maria Thomas, also breast cancer researcher. Also Dr. Mary Helen Hackney, medical oncologist. And I'm going to call you Dr. too, Wanda Lucas, because you got it going on. Breast cancer survivor and advocate. You all are so special in so many ways, giving us so much inside and outside, things that we thought about, things that we didn't think about. And then those unexpected questions, you all handle it like experts that you are. So again, we thank you all so much for just being here. Thank you, thank you, thank you. And also thank you, VCU Health, for sponsoring our National Women's Health Week program. This is so amazing. So again, thank you all. Thank you to our viewers. And again, we could not have done it without you. Amen.
Amen.
This is where we are. Also, we want to remind all of our listeners to make sure that you tune in tomorrow at 1 p.m. for our next episode of HERStory, RVA special broadcast for National Women's Health Week. Thank you all so much. And if you missed out on anything, you can make sure that you stop by our website at praiserichmond.com. We've got you covered. We love you. I love you all so much.
Thank you.
Thank you.
Thank you all.